Thanks very much for the introduction. It's really a pleasure to be here today and conduct this webinar. I, as Sue mentioned, have been co-convening this group for a really long time and feel particularly privileged that Sue and Miranda are new co-conveners. So I will provide an introduction to assessing the certainty of evidence with grade. Sue already referred to my affiliations that are relevant for today, but what is also relevant is, of course, a disclosure of potential interests. I do not think that I have any direct financial conflicts here today, but of course, I chair the GRADE working group, and I've worked with the Guidelines International Network. I also direct the WHO Collaborating Center that all have to do with evidence synthesis. I have grants. I have been a consultant to the WHO and the European Commission over time, and to some other agencies that are mentioned here. And I'd like to acknowledge Ignacio Neumann, with whom I work very closely on the great book that I will mention later on as well, and from whom I've taken some slides with his permission, because they are just wonderful slides. For today, what I thought to do, given that this is the introduction to a series of several webinars, what I thought to do is that I will provide background on GRADE and the GRADE working group and how this all fits with Cochrane. I will provide the context for why we are actually interested in rating the certainty in general and what else is relevant for Cochrane systematic review authors and why we are doing this work. And I feel that this is particularly important in the context of GRADE and for understanding the background around GRADE. And then I'll provide an overview of rating the certainty of the evidence. And here I will keep it to the most important parts around GRADE, with obviously in mind that a lot of the details that are required to understanding rating and the certainty of the evidence will be provided by subsequent speakers. So before I begin, I want to make sure that we don't forget why this is all being done and in what context this is taking place. So GRADE and the Cochrane Grading Methods Group came about because there were many, many different ways of assessing certainty of evidence, formerly called levels of evidence. And GRADE came about to unify and make transparent the use of a sensible system for rating the certainty of evidence. But it's also about making decisions. And I want to make sure that we don't lose track of that. And I think one of the biggest learnings that I had in the context of guideline development and decision-making, working with many organizations, is that whenever reviews are done in isolation, then they become much, much less useful. And I will give you a very quick example for why that might be the case. That is when we do a systematic review, of which, of course, many of us have done a number, or a large number, actually. Whenever we do systematic reviews and don't coordinate, for instance, which outcomes should be considered with a decision-making body, then these reviews become much less useful. And I will return to that. So that context is super important, and this is one of the reasons why GRADE exists. GRADE was actually, together with the Cochrane Grading Methods Group, initiated in collaboration with many, many colleagues, including colleagues from Cochrane, the WHO, NICE in the UK, the European Commission, US professional societies, the CDC, academic institutions, and altogether there are many, many institutions that were represented that helped to develop and utilize GRADE. GRADE is for systematic reviews and health technology assessments, as well as guidelines. It also has lent elements of its conceptual development to other disciplines, I would say. It's been used in obviously thousands of systematic reviews, if not tens of thousands of systematic, or more than 10,000 systematic reviews. And it's been used by many global health players, so which makes these webinars perhaps more interesting. We've produced a lot of material. We produce great guidance articles. We've obviously produced 2 Cochrane handbook chapters. And we have produced a new version of the great book, which has been around for over 20 years, really. But we just, in 2024, started to update this book. And I will explain this a little bit more because it's relevant for you as you are listening to this first webinar to see how to keep up to date with GRADE. There's an app that is utilized to create summary of findings tables and other things. That is the official GRADE app. It's gradepro.org. And I wanted to also remind everybody that the grading methods group, the Cochrane Grading Methods Group, as well as the GRADE Working Group by itself can be joined by anyone. It's, of course, free membership. And the benefit is working with wonderful colleagues, I think, and contributing to what we think has really been a major methodological contribution over the years. We have great centers and great networks across the globe, as you see on this slide, and they, of course, help with the further development of GRADE and the dissemination. Many of these centers are actually affiliated with Cochrane centers as well, Sue being one of these representatives, Sue Brennan being one of these representatives. But for instance, in the Czech Republic, there is a joint center in Germany, in Freiburg, and so on and so on. So that just tells you about the close alignment between the GRADE Working Group and, of course, Cochrane. I also wanted to take this opportunity because much of what I will be speaking about and what the colleagues are speaking about will have to be seen in context. As I mentioned, I also wanted to take this opportunity to just briefly review how this all came about. So GRADE actually started in the year 2000. So in 2025, just last year, we had our 25th anniversary. And we really started with initial meetings, reviewing existing frameworks for assessing the certainty, and have benefited from close collaboration with many, many Cochrane authors. I'll expand on that a little bit as well. And started to operationalize the certainty domains that I will describe in the year 2000. We published our first 2 articles, actually 4 articles in 2003 and 2004, which dealt with how to express the certainty. And then, of course, our first article about the GRADE system, as well as an evaluation of other systems, and started to develop GRADE Pro as a software tool, and WHO actually adopted GRADE in 2004 as well. We produced Cochrane handbook chapters, the first version, provided updates to the framework, operationalized it better in 2007, 2008, and then started to think about that GRADE not only should inform the certainty assessment in systematic reviews, but it should connect systematic review authors to decision makers. And we started working on what we called evidence to decision tables and frameworks, which indeed became, with our DECIDE project that Cochrane was closely involved with, became the rationale for our DECIDE project that made another big contribution on the evidence to decision frameworks, which I will also expand on. And then that project ran until 2015, and we think that we've now really started the second era. We've gotten much more into topics that over the last few years became more relevant, such as the use of artificial intelligence, considerations around planetary health, for which we have project groups that are working on that. And of course, all of that feeds back into the assessment of certainty around not only intervention effects, as I will explain later. We publish our guidance articles in the Annals of Internal Medicine and the Journal of Clinical Epidemiology, currently with two journals with which we have affiliations or agreements. And GRADE then, in a nutshell, has made, in my view at least, two big contributions. One is it was instrumental or developed the summary of findings tables. This is work that Andy Oxman, who was the original founder of GRADE, did or started in really pretty much around 2002, 2003, which provides a concise summary of the best available evidence for a given question by outcome with a certainty rating. And the second big contribution is, as I said, to structure the use of evidence in the evidence to decision process. We call those evidence to decision frameworks. And to me, this is very important. I will spend the next few slides actually on this context, because I want to emphasize that as review authors, we always need to make sure that we understand in what way our systematic reviews or evidence syntheses will eventually be used. And to many of us, this is a graphical overview that puts this into the context where it belongs. Of course, our questions start with typically a population intervention comparators and outcomes question, or interventions and comparator and outcomes question. And that leads to a systematic review or an evidence synthesis, of course, that brings together evidence from primary research. But we do this in the context of decision-making in a health system that includes, of course, health technology assessments and coverage decisions, the use of guidelines. So many of us work with guideline producers. And as you know, one of the metric that Cochrane uses frequently is how many WHO guidelines, for instance, contain or are built on Cochrane evidence syntheses. And this is apparently over 70%, if not more. But evidence syntheses are used for coverage decisions, as I already mentioned, that may be informed by HTA, for making decisions about the essential medicine list that are of extreme relevance, I would say, or very high relevance to, in particular, low and middle income countries that base their decision on essential medicine lists, often produced or mostly produced by the WHO. But we also inform policymaking, of course. And for that, these different groups use similar criteria. There's also some slightly divergent criteria that in concept, however, are overlapping. And our evidence reviews are also used for modeling and drawing conclusions, then recommendations for these first two decision makers there, and typically providing decisions or making decisions by these other decision makers, and options that are produced in evidence-informed policy-making processes in order to then, again, make policy for systems, but also to influence clinical and public health, which of course, we want to be implemented. And again, that is also evidence synthesis that we do, evidence synthesis of primary research that deals with implementation, which together forms that evidence ecosystem of health decision-making. And, building on that, I will have two more conceptual slides, because all of that is totally relevant for us. And I want us to be clear on why we do assess some certainty. To put it into more detail, that type of decision-making process or framework and the actors that play a role influence or should influence directly what we do in our systematic reviews. Typically, I'm going to use the guideline process as an example. Typically, it starts with some guideline group. We often call it a panel that prioritizes health questions. And this is then informed by systematic reviews. But we don't only inform systematic reviews of intervention effects. We inform systematic reviews of any of the criteria that are relevant in a decision-making framework. And ideally, all of that information, these reviews that are done, undergo a certainty of the evidence assessment before they are utilized in, as I said, a guideline or a health technology assessment process, and before they lead to decisions. And another overview slide that we often use, it's a classic, great slide, I would say, is this one that conceptualizes this process or operationalizes this a little bit more for those of you in particular new to GRADE. Again, a decision maker develops a population interventions comparator and outcomes question. GRADE is has made one major contribution amongst others in that we made very clear that not everything that is measured is important for decision making, and not everything that is important is actually measured for decision making. So we conceptualized how to prioritize outcomes that should be considered in a systematic review before you start assessing single studies and do an overall certainty of evidence assessment. In other words, that you prioritize as a review author the outcomes that are actually critical. And as you will know, we've moved from systematic reviews in the Cochrane library that often had 20 to 25 outcomes to a much smaller number of outcomes that are indeed then included in summary of findings tables. But years ago, that prioritization did not take place, which of course made it much harder to understand systematic reviews. But once that is done, systematic reviews are done that start, of course, with an assessment of single studies, but these single studies are not only assessed for how good they are or risk of bias, they are assessed for all of the GRADE domains that is put into summary of findings tables. These decision makers then use it in the way that I described it with the criteria that I mentioned a bit earlier, from priorities to desirable and undesirable health effects, considerations of equity, considerations of planetary health, cost, resources, and in general, feasibility and acceptability. They use this to make recommendations that are either for or against an option. And before they put this into some document, some norms and standard setting documents, such as a guideline that then uses the systematic reviews. Many organizations publish guidelines together with our systematic reviews in order to make the process evidence-based. But we deliver recommendations or decisions on the basis of our systematic reviews. So that was my bigger intro for these 8 webinars that altogether are taking place. So why are we doing all of this? And in what context does it take place? And a strong encouragement to those who are listening today to always check in with potential decision makers when we do reviews in order to make sure that they are actually relevant. But as I said, GRADE's first major contribution in the context of Cochrane was the summary of findings table. And here is an example of a summary of findings table, which of course is described in the Cochrane Handbook chapters 14 and 15. Here's an example of a elaborate summary of findings table. And our original version, of course, and then there are multiple versions that include the options of using number needed to treat or to use risk differences as opposed to using the risk in the comparison group or in the intervention group. So multiple modifications are possible, and I refer you to the relevant literature. This is really to just provide you with an overview, where in the summary of findings table, the PICO question is described on top. And then, as I said, a major contribution has been, and very important for summary of findings tables and the rating of the certainty, is to prioritize the outcomes that are relevant, such as outcomes for decision-making year-round anticoagulant treatments. But what I also wanted to emphasize is the extreme case that is relevant for decision making, where a review author not only provides a meta-analytical estimate of a relative estimate of the effect, but puts their findings into context and provides the estimates in terms of absolute effects for representative baseline risks. And here's an example for this particular question, the effects over a given time period, which is always described in the summary of findings tables, where they provide the absolute effects for different baseline risks, such as described as low, moderate, and high. Here, it's an extreme case. We suggest that you can use up to 3 risk strata, but sometimes you might choose only 1 or 2. But in order to make sure that your relative estimates of the effect from a meta-analysis, for instance, can be seen in context and used for decision-making, we suggest that also the absolute effects are actually provided. And here I use the original summary of findings table, where we provide the risk in the control group and the risk in the actual intervention group, which of course can be an active comparator. This is also very, very important to keep in mind. It doesn't have to be no intervention simulated with a placebo. The relative estimates of the effect, as well as the actual underlying evidence, such as the number of people enrolled in the studies, the type of studies, and a rating of the certainty. A section for comments, where we often interpret the results, or in the future will describe what additional research might be needed or where evidence gaps are present. And then, of course, that certainty rating comes with these explanatory footnotes that we've also done a lot of work on, where you describe why you might have provided a lower certainty rating than is perhaps anticipated or what you started with. And what becomes very obvious here is that for those of you new to GRADE, that every outcome might have different certainty ratings associated with it, which is a hallmark of GRADE and informs decision-making, in that the lowest certainty of the evidence for any of the critical outcomes, and you should only focus on critical or important outcomes, any rating of the critical outcomes informs the overall certainty. So what GRADE then contributed, and what is quintessential in the rating of the certainty, is the distinction between the magnitude of an effect, and for decision-making ideally expressed as an absolute estimate of the effect for a relevant population, from the actual certainty, or what we used to call quality of the evidence. These are synonyms, but we shifted to certainty because it was confused with quality of individual studies. So GRADE distinguishes these two core concepts. And what does it actually mean in a narrative, certainty of the evidence? So the way that we define the certainty of the evidence is as follows. GRADE defines the certainty of the evidence as the certainty that the true value of an estimate falls within a specific range, or above or below a decision-making threshold. And the next webinar given by Professor Rietschok will be focusing on thresholds. And this is already a primer that this is extremely important in the way that GRADE has developed over the last 25 years. And I will say that repeatedly, GRADE is basing its work on the evolution of science, and clinical science and systematic review methods, and think of the way that we look at imprecision, and the way that this has changed over time. So GRADE really goes with the times, and one of the big developments has been the decision-making thresholds. But how is certainty then expressed narratively when it actually comes to the rating? This, for intervention effects, represents that grade assesses the certainty in 4 categories, 4 levels, from very low to moderate to high. And again, it reflects the certainty that an effect is in a particular range or be above or below a certain threshold. In narrative terms, and this is work that has been cited widely from the Great Guidance 26. So we've produced many articles, as you know. Great then provides a narrative around this that also has been utilized, of course, in Cochrane summary of findings tables and is a good way of standardizing interpretation, where very low certainty evidence is interpreted as that the intervention may reduce or increase depending on the direction of the effect, the outcome, but this evidence is very uncertain, to a firm statement where a review author based on high certainty evidence would, for instance, be confident and say that the intervention reduces or increases the outcome of interest. And of course, with 2 levels in between, those are simply ways of expressing what falls between the very low and the high certainty evidence. Again, of course, these type of interpretations then can be made for all sorts of levels. And in order for you to then also talk to your scientific colleagues or other researchers, we've provided an interpretation of the certainty that is a bit more scientific. For high certainty, we say that there is high confidence that the true value of the estimate of interest is on one side of the threshold of interest. I'll return to that, or within a specific range. For moderate certainty, obviously there is moderate certainty, or we are moderately confident, but there's an addition that the true value of the estimate may actually deviate slightly from the target of the certainty rating. And so moderate certainty evidence still leaves us with a pretty good degree of confidence, but it may fall into a different range, as I will explain. For low certainty, again, low confidence, true value in this case may deviate importantly, or if more research is actually done, that estimate of the effect, despite being the best estimate of the effect at a given time, may likely fall into a different range or be different from what is described, down to very low certainty, where our interpretation is that although it's the best estimate of the effect at a given time, the true value of the estimate may actually deviate significantly from what we are currently describing and from the actual target of the certainty rating. And I want to use this opportunity, given that I was given the wonderful task to put grade in context and provide the introduction. I also want to use that opportunity to ensure that we, yes, think of interventions, and these are probably the most prominent systematic reviews, but that if we inform decision-making, we operate in this broader space. And grade has been utilized for other types of evidence summaries. So in intervention effects, of course, that certainty definition refers to treatment or intervention effects. But when we estimate patient values, it pertains to the actual relative importance of an outcomes, typically expressed on a scale from 0 to 1. In diagnostic questions, it may actually reflect the effect of a diagnostic strategy, or more commonly, actually, if test accuracy reviews are done, it refers to the diagnostic accuracy measure of a test. In prognostic reviews or evidence syntheses or prognostic assessment, it typically represents a measure of association between a predictor and an outcome. And in environmental health and risk assessment, it would describe the relationship between an exposure and an outcome. So the certainty definition and the way that we conceptualize certainty is relevant, but also tailored to the actual health question that we are asking. And I also want to take this opportunity, as I already mentioned, to make sure that we are I'm aware that the GRADE working group with members of the Cochrane Grading Methods group, of course, being there simultaneously, has thought very carefully for how to describe these concepts in a much more streamlined, simple, straightforward, totally accessible way. And we've updated the GRADE book that, as I said, has been around for a really long time, but that is freely available with different ways of getting answers from questions, including the support by AI, including what we call the GRADE Living Map, which is a aggregation or a repository of what is currently valid GRADE guidance, but of course with a living group of chapters that relate the concepts of GRADE and the operationalization of GRADE in a way that we are currently thinking about it. And of course, as I said, science is in flux, but there is a degree of stability, of course, so these chapters are not changed every day, but they are meant to be kept up to date. And so for this is also to make that connection for, of course, we have the Cochrane Handbook interpretation chapters, and what is there is, for the most part, of course, what Cochrane reviews should be utilizing in terms of how to conceptualize or how to put together summary of findings tables, and how to convert, for instance, continuous outcomes to dichotomous outcomes, or how to calculate a standardized mean difference, and all of that is true. But the official current guidance is actually in that GRADE book, which is kind of the final judge about the application of GRADE. And this is very relevant because, of course, many decision makers use GRADE. So I'll now go into more depth about these concepts that I already described, and I will talk about how to assess the certainty of the evidence. And as I said, this now focuses, after having given you the context and trying to not confuse you, that GRADE is also used for prognostic and test accuracy questions, etc. This is focusing on intervention effects. And what again, this will be followed is by specific topics of the GRADE domains that are being rated in the upcoming webinars. And so I will touch on them and provide a overview of them, but I will not explain them in detail because that would be in the individual done by the individual speakers who follow. But I will give you a background on how this is done in the year 2026 and give you some of the concepts or try to provide you with some of the concepts of what we are talking about. So risk of bias, of course, has to do with limitations in the study design and execution. And it is a risk of bias rating or assessment by study, but then across studies. Imprecision has to deal with whether or not there is sparse data or whether or not there's a sufficient number of events and people enrolled in studies. Inconsistency deals with whether or not results that should be the same, because we pool studies that we think are reasonably similar, are indeed showing different results, and it deals primarily with whether or not that inconsistency, where we use statistical tests for heterogeneity, is explained or unexplained. Indirectness has to do with applicability, generalizability, transferability. In other words, how directly do the studies that are in front of us inform the question of interest? And GRADE has done an update. You can look that up in the book in terms of how we bring together individual studies to an overall rating of indirectness through the indirectness table that, of course, is also part of Cochrane Handbook guidance. Dissemination bias and rating up the certainty are other categories or domains that we have operationalized. I want to make sure that for the time being, because this question often comes up, that conflicts of interest are typically covered in these existing domains. And conflicts of interest lead oftentimes to poor design. They lead to inconsistencies, such as using inappropriate comparators in some studies. They affect indirectness. They may lead to dissemination bias and so on. So it's not a separate domain. That question is often asked. Grade, as I said, has operationalized the rating of the certainty in a better way. So I will now explain that in some more detail. There's 4 steps. The first step, and I refer to that, starts with determining how many thresholds there are that we are interested in with regards to absolute effects. They may be established through consensus or empirical evidence, but they should be reported transparently, because otherwise we make these ratings implicitly. And I'll refer back to guidance for how that can be done. But as a systematic review author, I'll give you an example. It may be as simple as saying, okay, we did not have a broad consultation, but as our review team, here are the thresholds that we set at the beginning. A small effect is an increase, an absolute risk increase of 1%, a large effect maybe an increase of 10%. But these thresholds are consequential and necessary for rating certainty, and that has become more and more evident over time. We then determine the target of the certainty rating. I'll explain that also better, which is the second step in identifying or making a judgment about the rating of the certainty. And that typically corresponds to the range within the point estimate of an absolute effect actually falls. And the third step is an evaluation of the actual evidence. In that step, we determine, or we review the domains that I just described, including limitations in study design and execution, which will all be described in more detail in subsequent webinars. And then at the end of the day, we determine whether to rate down or up. That should be done after we've looked at the individual domains, because one important message in grade is that none of these domains are totally seen or should be totally seen in isolation. They are connected to each other, as you will learn about imprecision and inconsistency. They are informed by similar parameters. They are informed by effects of fixed effects and random effects, meta-analyses, and of course should not be seen in isolation, similar to risk of bias or inconsistency, which may be explained by studies having different risk of bias. So make your assessment, and then at the end determine whether or not to rate up or down. And that, again, is done in context. So that being said, the same principle applies to rating up. As I said, again, you look at all the factors, and if you have observational studies, you may rate them up. And one word on the thresholds, without going into the greatest detail here, but the thresholds inform simple things like evaluating risk of bias and doing sensitivity analyses. And this is actually described in great guidance that we put out quite recently for how you might actually get there. And for those of you who are fearful of setting thresholds for what are trivial, small, moderate, and large effects, I can tell you that you're doing it otherwise implicitly, and our experience is that this makes the work harder rather than easier if you don't set thresholds. And if you do set more thresholds, the rating, for instance, of imprecision and other factors is facilitated. And here is a quick example. So if you have a sensitivity analysis and the sensitivity analysis suggests that the effects are very different and you don't decide to exclude the high risk of bias studies, then you might rate down. If they are congruent, rating down is less likely. So let's go into that certainty assessment. So the certainty of the evidence, again, is about whether or not an effect falls in a specific range or above or below a threshold. So here decision thresholds, and here if the certainty is just beyond a threshold, then that can also be described. So let's start with an example. So for instance, if a meta-analysis suggests that there's overall moderate certainty in the evidence, that there's an overall moderate benefit, then your target of the certainty rating becomes that moderate benefit in absolute terms. And the studies may actually be disseminated like this. So that becomes the target of your certainty rating. You will realize that we've actually moved away from from focusing on statistical significance and the line of no effect. The target of the certainty rating is actually a range. So again, moderate benefit here being, for instance, the target of the certainty rating. If you had high certainty, then you would be pretty sure that this effect would actually fall into this moderate benefit range. And you could say, we are, this intervention leads to a moderate increase or moderate reduction of that outcome based on the certainty ranges that you set. Moderate certainty would mean that this effect could be different and that typically it would move beyond across another threshold. Low certainty would mean it becomes even less likely that the effect is in that moderate certainty range, and very low certainty means that it could be substantially different, several thresholds different. But that concept is critical for these 4 steps that I described a bit earlier in the certainty assessment. Those 4 steps being determining the number of thresholds, determining the target of the certainty on the basis of an intervention review, for instance, the evaluation of the evidence with all of the domains, and then at the end determining whether or not to rate up or down. And we will see in that very last session that Miranda will be giving is how you bring all of that together. I will use an example from a Cochrane review very quickly. Again, this is something that is more of a public health example, but I always find it important to make sure that people realize that GRADE is for clinical and public health. This is a review that looked at low carbohydrate versus a balanced carbohydrate diet for reducing weight and cardiovascular risk. And this is some slides from Ignacio, as I said, that I think are very well put together. What has been proposed here is that what we have utilized is the actual weight change as an absolute outcome. As an example, there were 37 randomized controlled trials. Weight change was measured at 12 months. So you see here the congruency with the summary of findings table, where you describe the duration of follow-up, the number of trials, and the number of individuals involved that would make it into the summary of findings table. And here's a risk of bias assessment across these individual studies. And you would utilize thresholds in order to interpret the actual estimate of the effect. Here, as an example, thresholds could be a 5%, 10%, or 20% weight change for a person with an average weight of 100 kilograms. So our threshold could be 5, 10, and 20 kilograms for trivial and small, moderate, and moderate to large thresholds. And very important, the middle range here. Again, we de-emphasize this line, and in other graphs, we actually have taken this out to make this a bit more clear, because there is no such thing as no effect. It's probabilistically not possible. So just as a reminder, we would then be rating our certainty. If we look at the mean difference here, which is a 1.07 kilogram reduction in these studies, we would be rating our certainty that there indeed is a trivial or no important effect that is less than 5 kilograms, with confidence intervals mentioned here. So the target of the certainty rating is trivial or no important effect. And the way that GRADE actually helps you do this is then, here's an example starting with the judgment about study limitations. In other words, whether or not there are limitations, risk of bias in the individual studies in terms of execution and planning. The one way that the thresholds help you with is, for instance, in a sensitivity analysis to distinguish between the high risk and low risk of bias studies. And if there's concern and pre-planned a sensitivity analysis, then the estimates of the effect of both the low risk and high risk of bias studies would be congruent. And under those circumstances, one might not rate down for risk of bias because they fall within a threshold. And rather than making this judgment ad hoc, this judgment is actually done in a way that the thresholds informed it. The next example that I want to give you, and where the thresholds are so important and where the risk of bias assessment, of course, is fundamental for study limitations assessment. Next example, just quickly, that I want to give you where the thresholds are critical. And one of the criteria that we are, of course, utilizing is for imprecision. The thresholds actually help you with making judgments about imprecision. And what we say is that if thresholds for small, moderate, and large effects are not crossed, then there is typically no concern for imprecision. The more thresholds are crossed, and you will learn this in the corresponding webinar, the more thresholds are crossed, the more uncertainty there is, and the higher is the number of levels that we would be rating down. And the very simple rule, as you will learn, is that for each crossed threshold by the confidence interval, we rate down by one level. So what I have provided you with is an overview of how GRADE is utilized in rating the certainty of the evidence. I have provided you a couple of examples of how this works and how this context actually should be utilized in order to do your review. In summary, what I have presented today, before many of the sessions will go into great detail, is the background for how GRADE is utilized and how it's emerged over the last 25 years. Our two key contributions, which are the certainty of evidence assessment and the summary of findings tables, where we assess the certainty and an intervention effect. And by certainty, we mean whether or not an effect falls within a particular range or across a threshold, below or above a threshold, based on the domain's risk of bias, indirectness, imprecision, inconsistency, dissemination bias, and eventual upgrading domains, and how this makes it into a summary of findings table. I've mentioned that this is done for making decisions or supporting decisions, otherwise no sense in doing a review, and how the thresholds inform our certainty ratings. I will stop here with this intro to our webinar series.
Thanks, Holger, for this very nice overview. We have a couple of questions. We have 7 minutes and a couple of questions, and a lot of love in the room, I see, so that is excellent. The first question is, can GRADE be used outside the healthcare context? Can it be used for education, climate, and so on?
Okay, I can take this question. I mean, I like to take the, excuse me, I like to take the big picture perspective. And in my view, of course, it can be utilized. So let's say climate change or environmental health. This question has been a question for 25 years, whether or not we should be using different standards for certainty assessment based on the topic area that we are dealing with. Our response has been, certainty is a continuum on some sort of absolute scale. In other words, we are either 100% certain or 0% certain, and the type of question that we are asking about an effect of an intervention, such as in climate change interventions, should not be driven by the available evidence, but by the actual certainty level that could be utilized. So the domains in GRADE and the evidence to decision frameworks would apply there. And just as a quick note, We have one great project group that, for instance, focuses on education, not health education, but education in general, where we've learned that these concepts are applicable.
Yes, thanks. Another question is, can I use grade when I don't have a meta-analysis, when a meta-analysis is not feasible? And a related question, should I always do a meta-analysis before assessing the certainty?
Wonderful question. So, of course, the webinar has a limited duration. Miranda, that's a hint. That's for your webinar. But the point, two issues. One is grade can be utilized, and there's guidance out there when there is no meta-analysis. It's of course a much less quantitative approach, but it can be utilized. Same domains apply. And then, of course, grade can also be used for qualitative evidence. I didn't mention it here, but that, of course, is a different body of evidence, and it's not about intervention effects. But to answer the question, you can use the 5 domains without having a meta-analytical result. I didn't give that example today, but I'm sure Miranda will cover it. The second question is, should you first do a meta-analysis? I think you need a protocol, right? Your protocol should specify what you are doing, and if you can do a meta-analysis, I will say the use of grade is facilitated. It's easier to do it because you have harder criteria to go with. So as long as you have a good protocol with sensitivity analysis and subgroup analyses and so on, then a meta-analysis, I would say, will help dramatically, and I would suggest to do it again, always consistent with eventual protocols.
Thanks. Next question is this about the disagreement when 2 researchers are assessing the certainty of the evidence, let's say for study limitations, and one researcher says, I want to downgrade, and the other one says, no, I do not downgrade. How do we deal with that?
Yes. So I would say the approach in general is similar to inclusion, exclusion of studies or interpretation of risk of bias, where things being done in duplicate with consensus finding and potentially a third, sometimes I will use the word senior, but a person more experienced, would then help with finding a judgment. First thing to say is that I think it's always useful to say that this discussion actually took place and that there may be different interpretations, but I would use the same approach that we utilize when we include or exclude studies if we do it by hand. Miranda, I will take the opportunity. Grade is doing lots of work on using AI for rating the certainty. I think eventually, especially with the thresholds, we will be supported by artificial intelligence or automation. But I also think that the thresholds will actually help with the problem that was just posed, because it makes the rating more transparent, and it makes disagreement, because we can produce better rules, and unfortunately rules are important. We can provide better rules, disagreement becomes less likely.
Yeah, thanks, super. 2 minutes left. Could you please explain for those who are new to grade the difference between risk of bias and grade?
Okay. Risk of bias is an assessment of internal validity or limitations in a study design and its execution. It focuses initially on the assessment of an individual study. And again, it has to do with how well the actual result in a study represents the potential truth for the internal results that are obtained. Risk of bias in grade looks not only at risk of bias, but at other domains that are critical for assessing whether or not a systematic deviation from the truth is present. And that includes, of course, indirectness, inconsistency, and these other domains. Risk of bias only focuses on one domain. Grade focuses on everything that influences our certainty at the end of the day for a particular result.
Thanks. Maybe the last question, or maybe not. Can you use grade if you only have one study?
Same approach is being taken. One important note, and in our summary of findings clinics, that of which we held many with Cochrane, this question came up repeatedly. The only thing to note is that, of course, a single study cannot be inconsistent. It is unlikely to fare very well on a grade certainty assessment, because a single study is likely to be imprecise, indirect, and have other issues. So it's not in any way put in an advantage, but inconsistency is not present when there's a single study.